Our next speaker is Dr. Sidney Cash. Dr. Cash received his MD and PhD from Columbia University and went on to do his clinical training in the Harvard Neurology Residency Program. Afterwards, he completed his fellowship in epilepsy and neurophysiology at Massachusetts General Hospital. And currently, Dr. Cash is an epileptologist and researcher at Massachusetts General Hospital, and also an associate professor of neurology at Harvard Medical School. His research is focused on basic and translational neuroscience, where he uses micro and macro scale recordings to learn more about the abnormal and normal brain rhythms. He uses this knowledge to create new interfaces to improve the lives of patients with neurological disorders, especially in epilepsy. And today, Dr. Cash will be talking about seizure initiation, termination, and the networks behind those phases.
Thank you, Homain. Thank you very much to the organizers, Levin and Mark, and the rest of the group for having me come down to give this talk. It's really quite an honor to come here and to a conference which I think is really becoming one of the really premier conferences in the epilepsy world. And I'd like to just modify one thing that Homain said. I think he implied that I've actually done something to help patients with my research making devices, and we're not there yet at all. And that's really what this talk is about, is trying to get there little bits at a time. So first of all, I also realize with the limit of time that some things I cannot talk about. So I've dropped the termination aspects of the talk entirely. And if that's something you're interested in, please come let me know, and I'm happy to talk about it some more. So what I'd like to try and do in the next 20-odd minutes is discuss some of the results from what we call a multi-scale approach, which dovetails with some of what's been discussed yesterday, this morning, and this afternoon, to better understand the seizures. And we use these techniques, as was mentioned, where we get single-unit, multi-unit, local field potentials, as well as ECOG-based information, structural information as well, from focal seizures during patients. And the assumption here is that this information will be useful to us in designing prediction and control approaches. Some of the questions that we'll be asking and giving a little bit of information on today are really basic ones, really. What more can we learn about seizure initiation from actually recording this multi-scale information? One such question, again, one that's come up a couple times already in the last day or so, is how focal is focal? Is it really a focal change that we're looking at? And also, are there preictal changes in this other modality, if you will, these smaller scale modalities of single unit and multi-unit activity that might be able to be used in some prediction approaches? Once the seizure gets going, how does it actually then spread? A question was asked in the last session about what does it really matter, what's going on in propagation? And I think that it's a very valid question, and there are some reasonable answers to it. One of which is that for many patients, it's the propagation that really gets you. Right? If it stays focal, that might not be that big a deal for some patients. But it is the propagation in many patients that really can be a bigger problem as well. In addition, if you want to intervene in a control sets, then it might be useful to really understand how it is that you go from a relatively localized area to a larger area, as that might be one point of control. So we want to look at what happens during that propagation at these different levels. And finally, I'll go on to summarize that. So let me start with the issue of how focal is focal. Now, there's a variety of different evidence and suggestions. Again, you've heard some of this already today, brought up in a number of different talks or yesterday. What does it mean? What do we mean by focal? And there's sort of clinical definitions, and there's research definitions, there's physiological definitions. I think there's a fair amount of evidence that even seizure etiologies that we think of as quite focal are, at least in some sense, not completely focal. If you take mesial temporal lobe epilepsy, for example, you've got a patient with clear-cut mesial temporal sclerosis on their MRI. Perhaps they've had a history of febrile convulsions, as was discussed earlier, and you look at their structure and functional imaging and EEG, you actually find changes that are outside of that area where the seizures presumably emanate from. So you could find, for example, widespread changes in white and gray matter. This is something that Richard Stabler, UCLA, and that group has looked at amongst other people. You could look very common clinically. If you look at a PET scan, you can see that the whole temporal lobe will show hypometabolism, even though later on in this patient or a patient like this, you might put electrodes in, and you see that the onsets of those seizures are actually really quite focal. They're coming from a couple contacts right in the hippocampus. But it's obvious that that larger areas are affected. This is part of what feeds into our concept of the idea of network activity and network structure is somehow related to the seizure onset itself. In addition, we know that there are physiological changes at or before seizure onset outside the seizure onset zone. This is embedded in many of the prior seizure prediction approaches that have been used. That those channels that are outside where the seizure might start can still be useful in predicting in some circumstances in some patients or in detecting seizures. And this was shown a little bit more clearly in a paper from a couple years back from John Gottman's group by Peruca, looking at changes in and outside of lesional, non-lesional seizure onset zones, and showing that there are changes in power that actually occur before the seizure actually starts. We've done some similar analysis with macroelectrodes, looking at changes inside and outside of the seizure onset zone in patients with purely mesial temporal onsets of their seizures. An example of which is shown here from one patient from a depth electrode that was recording from the hippocampus, clear, nice onset of the seizure, and a simple spectrogram of a time of 1 second around the onset, change in the spectrogram as the seizure gets started. And what was interesting is that if you look outside, in this case, an electrode close to the cingulate, but electrodes elsewhere, you can actually see that there are some spectral changes in other regions outside of the focus right at the start of the seizure. And if you go through a fairly rigorous quantification of this, compare it to baseline epochs that could span the entire course of the patient's recording session, you can see that there are small numbers of electrodes which show a change, in this case, increases in power in different frequency bands, particularly the lower frequency bands, just as the seizure gets started outside of that focus. So another little piece that contributes to this idea that what's happening in the focus is not the only place where the action is for seizure initiation. On the flip side of this story is data from Greg and Kathy Chavone using microelectrode arrays of different sorts, Utah array in Kathy's case and microgrids in Greg Worrell's case, and finding these events that are very, very focal of ictal-like activity or that generally precedes the seizure, but are occurring on just a small number of contacts on the grid, suggesting that, again, what we think of as the focus at the spatial resolution of a macroelectrode might not really be the full extent of the story, and there might be some heterogeneity in that spatial structure, such that there are patches that are more or less part of the seizure focus. So we sort of have two flip sides here. On the one hand, there's extrafocal activity that might be contributing in some way to seizure initiation, and in that area that we think of traditionally as the focus, there actually might be heterogeneity there as well. And I think these are two important concepts to incorporate into our thought process of seizure initiation. Let me give you a little bit more evidence that there can be things that are occurring outside the seizure initiation zone that are important. And I'll start with some microelectrode recordings using a laminar microelectrode array system. This is a system that was developed by István Ulbert of Hungary in collaboration with his mentor George Kormos and with Eric Halgren, my former mentor and continued collaborator. This is basically a linear array of electrodes that spans around 3.5 millimeters, spaced at 150 microns, and it's designed to cover the gray matter of human cortex from the peel surface down just above white matter in most cases. And it's very good for giving you recordings of local field potentials in a way that you could calculate current source density, and I'll show you some results of those in a few minutes, but also pick up multi-unit activity, and if the stars align properly, single-unit activity as well. And with this system, you can actually detect changes in multi-unit activity that seem to precede seizure onset. Here's just an example from one patient, one contact, in a time span of around 30 minutes before a seizure, where there's this slow increase and then sustained increase before a drop in multi-unit activity before the seizure actually gets going. I'm looking at 12 patients and 19 electrodes inside and outside of the seizure onset zone with this technique. Peter Rosman, a student in the lab, has analyzed that data and compared it to a series of interictal periods obtained from that same data recording, and then using a binary classifier can actually get reasonable value for classifying whether a given segment of data is in fact pre-ictal or not. Now, it's not getting to the stage of prediction at all. It's just showing that there is a change in this particular parameter in certain layers of the cortex that occurs before the seizure is initiated. Whether it's robust enough to actually be used as a predictor is something that we're actively working on, but is a challenging task. But I think it shows clearly that there are changes beforehand, and these can be both inside and outside of the seizure focus, because these laminar electrodes were placed in locations that we thought were going to be seizure focus, or which we could place them in that were near seizure focus, but were going to be resected, and therefore not always inside the seizure focus. In fact, most of the time they were not in the seizure focus, and yet these changes were present there. We have similar findings using the multi-electrode array now from BlackRock, which they call the Neuroport array. You've also heard it called the Utah array. It has about 3 or 4 other names. It's all this 100-shank, 4 millimeter by 4 millimeter set of electrodes that are 1 millimeter or 1.5 millimeters in length as we use it. That's placed into the cortex, again, in regions that we are expecting to remove and that ideally are close to the seizure onset zone, but may not be for various reasons, and from which we can get single unit activity over the course of the time that a patient's hospitalized for localization of their seizures. And this system is extremely good at giving you multi-unit activity and good at giving you single unit activity. Unlike the laminar probe, it's really giving them only from a single layer in cortex, so you don't get that information on the circuit dynamics, but you do get a lot better recordings of single unit activity. And with this system, Wilson Truccolo and I looked at data from patients in whom there were focal seizures that then spread, and saw again that there were changes in single unit activity that preceded the onset of the seizure. A couple examples are shown from single electrodes, single neurons. These 2 neurons are from the same seizure, one of which increased 20 minutes before the seizure, one of which increased and then decreased. Whole other seizure, different neuron entirely, had a bit of an increase about 10 minutes beforehand and then did it again an hour or so later when there was a second seizure. You could look at this and say, well, that's all well and good, but it tells me nothing about any consistency as to whether or not these unit changes are occurring with regularity. Perhaps, this particular set of neurons were going on and off because of some state change, or they were doing something else, watching their favorite TV show, and that neuron likes that TV show, and so it went up, and they happened to have a seizure. When we looked at the whole group of neurons, about 1,000 neurons total, and analyzed just a brief period of time before the seizure onset, 3 minutes, and compared that to a large series of baseline recordings of that same neuron, and then looked at what was the variability in unit firing for those baseline periods compared to the change in the unit firing in that 3-minute period right before the seizure. We found a number of units, that did this kind of thing. The trajectory was outside of the range that was seen in the interictal. They either could be high, as shown in this case, preictally, and then they drop down ictally, or it could be the reverse. They could actually drop, show a much lower firing rate right before the ictus than they did either preictally or during the ictus itself. Now, again, it wasn't a huge effect that every neuron was doing this that we recorded from. It depended a lot on the particular patient. But in general, we were finding 10-20% of our neurons that we could record were showing some change in that period of time before the seizure onset. And in 3 of these subjects, those recordings were done outside of the seizure onset zone, so outside of an area where the seizure was emanating from, at least by ECOG criteria. So taken together, these results suggest that there are changes outside of what we would traditionally call the focus of the seizure onset zone. And again, that's not necessarily a completely novel idea. It's just adding weight to it and giving us some more characteristics of what exactly is changing. We see this in the single unit level. We see this in the multi-unit level. And there's also this idea of these micro seizures occurring, giving you spatial heterogeneity within the focus itself. There's a lot of questions about this kind of data. Does this information generalize to different seizures, etiologies, locations, and different circumstances? Is there enough here for a predictive signal that would be useful? What are the time frames and the consistency of these changes? And what actually is necessary and or sufficient here for the seizure to begin? We don't have any real handle on whether or not the changes that we're seeing are just reflecting another process, an underlying process. Are they actually driving the system? Are they permissive? What exactly is their role as we move into the ictus itself? Then once the ictus spreads, what are the mechanisms that underlie that propagation from a given region outward? And that's what I'd like to talk about next for the next few minutes. First of all, one of the things that we found that was quite interesting in that first analysis of macroelectrode data, depth recordings from patients with mesiotemporal sclerosis, is that what was happening in those extrafocal areas was actually indicative to some extent of what would happen during the seizure itself. We found that if there were changes in, particularly increases in slowing in areas outside the focus, it was likely then that the seizure would go on to generalize. And that's shown here, where we've broken out whether the seizures remained focal or whether they secondarily generalized, and there were larger and more consistent changes in broadband power in extrafocal areas. So this is the focus, the ipsilateral mesiotemporal lobe, and then these are areas outside of the seizure focus. And even in if you broke it down by different power, and the seizure generalizes, you were seeing this slowing much more consistently for those seizures that went on to generalize. So something that's happening outside in the network as a whole is in some way influencing what happens next in terms of seizure propagation. And as the seizures propagate, they propagate in a fairly somewhat characteristic manner, that is relatively slowly in many cases. This is a series of 16 patients that we looked at with ECOG grids and nice clear-cut focal onsets that then went on to spread. And in general, it took at least a few seconds for other areas to become fully engaged in the seizure, and as long as 40 to 60 seconds as well. And you see this clinically when there's an onset that then has a clinical manifestation perhaps, and later on there's a larger and larger clinical manifestation as that seizure spreads to other locations. What was interesting is that in some patients, this spread was actually well organized. This is an analysis of the temporal sequence of spreading as measured, looking at changes in power, standard deviation of power over time. You could use any number of methods to determine where the onset of the seizure is on any given electrode, and they give you essentially the same information. But in some patients, you see a nice spread that begins in one place and then begins in one place and then sort of cascades outward in a fairly regular fashion. In other patients, you don't see this nearly as much. You see a much more complicated organization, less of a clear sort of linear pattern of spread across the cortex. It turns out that these patients in general have a worse surgical outcome than the patients who have a nice clear-cut pattern of spread and generalization. Even though the original foci of these two things could look essentially the same, that is, the area where the focus was thought to come from was equally well distinguished in both situations, the degree to which it spread in an organized fashion could then determine to some extent how well they did at surgical outcome. Now, what's happening microscopically as the seizure progresses from a focal point out? And here again, we looked with the neuroport arrays. This is work done by a grad student working with Wilson Trukalo, Fabian Wagner, looking at multi-unit activity as well as local field potentials as the seizure propagates. And a number of different patterns were seen here on the neuroport arrays, some in which the propagation of multi-unit activity as the seizure invaded that area where the neuroport array was localized was relatively consistent, relatively linear over time. But occasionally you see propagation patterns where it's much more complicated, much more various as it goes across the multi-electrode array. Now this data, I think, complements some of the work that Kathy Chavone and Andrew Trevelyan have presented on multi-unit activity with these same neuroport arrays, where they find inside the focus a relatively fast spread of the multi-unit activity, but outside of the focus, particularly in this area that they're calling the penumbra, you see this slow cascade of multi-unit activity even across this relatively small space of 4 millimeters by 4 millimeters. Before then, the seizure sort of becomes active there, and there's large amplitude LFP correlated with high-frequency data. In our hands, we see that. On occasion, we also see other patterns where the multi-unit activity doesn't really have a clear-cut peak, that there can be large amplitude LFP and gamma coherence before that multi-unit peak has passed through that area. And we also see the somewhat tricky circumstances of low amplitude, high frequency seizures that start that way and stay that way, that don't really have a clear peak in the MUA in anywhere. They just have sort of consistent elevated multi-unit firing during the whole course of that seizure without any real evidence of there being a single peak that then traverses across the array. So, overall, we're seeing a lot of slow propagation across the cortex as a whole, even on the micro scale as well as on the macro scale, and that can be quite variable as things progress between different patients. You could use this progression, this MUA LFP progression, to characterize what's happening in the dynamics at the local scale, the small scale, in a number of different ways. One of which here is to take the LFP information and then take multi-unit activity information, quantify that, and then look at sort of a similarity matrix over time, where each time point is compared to the time point before it. And when you do that, you can create a matrix of the distance from any time point to the next. And as you do that, you end up with these fairly clear regimes that you're going through. You can see this by eye as well, that there are different periods during the seizure onset itself that can be sort of broken down and turned into different stages. And this raises an issue of, and this is talked about in the last couple of talks, are we, as we're progressing through the original start of the seizure, through propagation, are we transpiring through a series of different stages, a series of different states, or is there some other more continuous process that's going on? And this data would suggest that we are sort of moving through semi-stable states as we start the seizure and progress onward. You can take this information and condense it still further, where you can characterize your multi-unit activity, you can characterize the spatial similarity, take these multiple dimensions and then collapse them into a trajectory of what's happening during the seizure itself. These are 3 examples from 3 different seizures in 3 different patients, showing fairly different kinds of trajectories as the seizure starts. And in fact, comparing one patient to the other, it's quite hard to find very clear similarities between patients. However, in a given patient, it seems that seizures are usually fairly constrained in their mechanism. So here are, again, 5 patients that we've analyzed with this approach and looking at their trajectories, and they're reasonably similar from seizure to seizure, both using that technique and then just sort of looking at LFP frequency characteristics as well. So within a patient, we see that as a seizure propagates, it seems to be doing so with similar dynamics compared to other seizures in that same patient, but it can be quite different from patient to patient. Now, as this activity is propagating across the cortex, we've looked at what's happening at the single unit or multi-unit level in combination with the LFP, what's happening at the different layers of the cortex as the seizure invades a particular territory. And here the laminar electrodes could be quite helpful to us because they're giving us information from that PL surface all the way down to layer 5 or so. As an example of a recording where the laminar microelectrode was in the seizure focus itself, the patient had a tumor that was going to be resected. The electrode was placed just adjacent to that tumor, and the seizures emanated from there, at least on the ECOG recording. This patient had a lot of interictal spikes that were recorded with the laminar microelectrode, and they allow us to look at current source density and multi-unit firing during the event. And let me just spend a minute or two going through that. On the colorized background is time. Time 0 is centered at the peak of the fast component of the spike. And you can see this red blob here is a current sink with a return current source above it. And this is approximately layer 4, layer 5, based on the depth from the cortex. Overlaid on white is the multi-unit firing that we collect from those electrodes at those different heights in the cortical gray matter. And you can see there's a little bump in multi-unit activity. There's this fairly low down sink in layer 4. As the seizure starts, we can continue collecting the spikes from within the ictus itself, if you will. And you don't see a lot of change in this overall pattern. There's still this sink down low. The multi-unit activity gets bigger and faster and sharper. The sink stays deep. It might involve slightly lower cortical areas as it goes on, but really not a tremendous change in the overall characteristics of what's happening there. Certainly not compared to what we see outside of the seizure focus when a seizure comes to propagate to get to that area. So this is an electrode that was relatively far from the focus. The focus ended up being basically in mesial temporal structures, and our laminar microelectrode was on the lateral surface of the temporal lobe in the middle temporal gyrus. It took a few seconds for the seizure to propagate there. Unlike the prior example, there weren't actually any interictal spikes that propagated out to that area, so we don't actually have interictal spike recordings on the laminar. Once the seizure starts, however, we get these little ictal waves which show up as a sink in the upper layers now, very different than what we see when we're inside the seizure focus itself. And there's a small amount of MUA change, multi-unit activity change there, and probably lower down as well. It's not terribly impressive. But as the seizure progresses and we get these larger waves occurring deeper into the seizure, as the seizure is now fully invaded that territory, we see that this sink is now this sort of big blur of activity involving not only upper layers, but actually earlier in the event, involving deeper and deeper layers, and looking to some extent more like what we see in the ictus itself. In addition, there's much more multi-unit activity now, although it's spread throughout the cortex in different layers. We've seen this in a number of patients that as the seizure spreads, as the seizure gets more involved in that area, we see deeper foci for the current source density, that is, deeper current sinks for any ictal event. And this suggests to us that we're now seeing different patterns of circuit activity, whereas at the first part of the seizure, we're seeing synaptic inputs primarily onto the upper dendritic trees of cell bodies that are probably down in layers 3 and 4. But then as the seizure progresses, we're now starting to see a greater degree of synaptic activity occurring in those very layers, in layers 3 and 4 in particular, suggesting that there might be recurrent collaterals that are now activated once the seizure has become local, if you will. Single unit activity during this particular period is also undergoing a series of changes. This is now back to neural port data, where we've recorded multiple neurons during the course of a seizure, in this particular example around 150 or so neurons. And they show a variety of different patterns, an increase at the beginning for many of them. Some of them have sustained firing throughout the seizure itself, other ones that firing comes on and off, and still others actually decrease their firing as the seizure progresses. So quite a bit of differences in different neuronal types and different neuronal actions as the seizure progresses. Now, that degree of heterogeneity is quite dependent on where you are in the seizure and what kind of seizure it is. In some seizures, that heterogeneity continues throughout. In others, it actually becomes much more regularized, and these are particularly true in spike wave seizures, that you might have an early period of low amplitude fast activity and other sort of messy seizure activity, and then once you get into this regularized, nice spike wave during the clonic portion of the seizure, you see much more regularized neuronal firing. So that's raised the question that's come up a number of times as well. So is there really good neuronal firing synchrony in seizures? Are they really hypersynchronous? And my answer to that is the very wimpy yes and no. It depends on what you mean exactly by synchrony, what degree of synchrony is synchronous enough for whatever your question is, and what kinds of seizures you're looking at. These low amplitude fast seizures that we see don't really show much synchrony on almost any measure. Other ones that become nice spike wave events at the end certainly show, and this is a blow up for toward the end of the seizure, show fairly synchronized neuronal activity. Although if you're looking at the scale of milliseconds, it's still not that synchronous. They're still spread out quite a bit. So I think that early in the seizure we do not see almost ever that much synchrony. Later in the seizure, as the seizure sort of coalesces, we do. What's happening with individual types of neurons as the seizure progresses? This is work from Omar Ahmed in the group. He's looked at parsing inhibitory and excitatory neurons based on these recordings, which can be done based on wave shape. And he's been able to find 20 putative interneurons that are very conservatively classified as having a different wave shape from regular spiking pyramidal neurons. This is just a couple examples of cells from one patient and some other examples just for variety. In the green, I'm showing an excitatory cell recorded on the same electrode as the inhibitory cell, and the histogram is the inhibitory firing. You can see that the seizure starts. In this case, excitation begins. This inhibition cell then goes up. It's sort of inverse to the excitatory cell. It goes up, and then it drops. It goes actually to 0. We get no firing from that inhibition midway through the seizure. Here's another neuron, another inhibitory interneuron, slightly different place on the grid. It does the same thing. Starts out, has a big peak, gets up to a reasonably high firing rate, then drops down and stops entirely. Similarly, other neurons in other patients do the same thing. These happen to start a little bit earlier in the seizure, which gets to a point raised a couple of talks ago, is the role of inhibition early on. I think we don't have enough data to really say anything conclusive. We certainly see examples where inhibition is very large, very early on in the seizure, maybe before excitation is large, but we see the reverse as well. However, what we see very consistently is every single neuron that we've looked at that is classifiable as an interneuron stops firing about midway through the seizure at a point at which the LFP gets very large and often very close to the point at which we switch to clonic activity if it's a tonic-clonic seizure. Why are these neurons doing that? Well, I think the answer was partially given in Peter's talk or a little bit earlier on. Whether it's potassium or not, I don't know, but they seem to be entering depolarization block. And this is an example of two different neurons in two different seizures, where as the seizure starts at time 0, the amplitude of this action potential decreases quite rapidly until it disappears entirely. There's then no firing of that neuron for quite a while. And then The seizure has ended here on this fine line you probably can't see. We're in a postictal state here, then slowly this neuron's amplitude climbs back up again until it resumes its prior firing rate and prior firing amplitude. We see this even in very short seizures. So here's a seizure that's only around 40 seconds long or so, a little bit longer. Again, amplitude of this interneuron drops down quite a bit until it stops entirely. Then there's a postictal period and the neuron's amplitude climbs back up again until it resumes firing. So, in summary then, this sort of combined macro-microscale information has given us further idea that there are changes outside of what might be traditionally called the focus, and this is particularly true at least in one analysis with seizures that then go on to generalize. Seizures seem to be preceded by changes in single neurons and by small groups of neurons, and maybe this is something that will be useful overall. The spread of seizures appears to be relatively slow and can be either organized or disorganized. Patients with organized seizures seem to do better overall from a surgical point of view. And then finally, the early activity in the ictus is fairly complicated with the relationship between local field potentials, individual neurons, or group responses quite dynamic during that early stage of the seizure as the seizure starts and spreads. I didn't show some other data about what's happening with network properties as you go, but they're changing as well during the whole course of the seizure. So we're working on models of how to incorporate this into sort of a spatial and temporal model of the seizure. I won't go into this, but if you want to discuss it with me afterwards, I'll talk because of time. And let me just very quickly, before taking questions, if I have a few minutes for that, thank, first of all, the patients who are involved in these studies. They are instrumental to all that we do, allowing us to do these experiments, look at their data, and engage with them. And then also, I particularly want to thank Omar, who's done a lot of the work on the single unit analysis, as well as Wilson and Fabian, who have done a lot of the more recent analysis of MUA and local field potential analysis. And I'll end there. Thanks very much.
Thank you, Sidney. Questions? Yeah.
I had a quick question. Is there evidence to suggest that these extra-focus changes are actually good targets for neuron stimulation and modulation?
Excuse me. I have no data that would suggest that they either are or are not targets. I mean, part of the reason we're looking into them is maybe they could be, right? But I don't think there's enough data here to really make that suggestion yet. So I think that's certainly an area we want to think about and go toward, but I just don't think we have enough data to really say that for sure.
Hi. I just wondered, so we've seen a lot of evidence today, I think, that large-scale brain networks are quite critical in the initiation of seizures. Perhaps a telling example of that was this morning, where we saw that scout EEGs seem to be able to predict seizures better than intracranial, presumably just covering local networks rather than global networks. So I wonder how you feel you might be able to extend your work to sort of take that into account, given the sort of current state of the art, which is basically to only advance electrodes where we kind of believe the focus is, given that this may be an outdated concept.
Right, and I think this will come up in the breakout groups, whatever they're called, next, is sort of what are the signals and what ways to look at things, and I think it's a great question. I think that as we gather more information about understanding the networks like you've talked about and other people have talked about over the last couple of days, and we'll talk about tomorrow and some more, and we are getting this kind of data where we're explicitly looking at and examining closely what is happening in areas that previously we might not have paid a lot of attention to. We'll be able to sort of in a logical fashion come up with signals we should specifically and intentionally look at that can maybe be helpful to us in some way or another. But exactly what those are and what you're going to be good or not, I mean, we've already spent, not me, but many groups have spent the last couple of decades doing that in sort of a global sense, right? They look at seizure onsets from all the electrodes all at the same time. I think that now we need to sort of step back, maybe be more parsimonious about looking exactly for particular changes in particular regions at particular times. That might be a better signal and might be a better feature to add into any sort of learning algorithm or what have you to try and do it. I don't know if that really answers, but that's, I think, the way we're going to need to go.
Okay, one last question, and there's...
Yes, sir.
Fascinating data, very, very interesting. Just one methodological question. When you follow individual neurons who change their amplitudes to such a degree as you show it, how can you be sure that it's the identical neuron? Because normally amplitude of the discharge and the pattern of the discharge is critical in order to be sure that it's the
Right. It's a fundamental question and a fundamental problem when trying to look at this. And there are certainly cells that can get clustered, that can be put aside, which have so many changes that you can't follow them. But the neurons that we look at very carefully from time to time is the amplitude and the waveform shape changing in a way which is consistent and followable. So you could actually follow the trajectory of that waveform over time. You're not just taking a snapshot at one point and a snapshot at another point and saying, are these related? But you're actually following it over time. And that can give you confidence that you are, in fact, following the same cell. In addition, you're excluding yourself to a single channel of the single electrode, so you're not mixing and matching electrodes in any way. And you could look for that, like we showed in those two examples, you could look for recovery of that cell afterwards. So you have to, since we have, by dint of the actual data, this sort of symmetric process, it's extremely unlikely that symmetric process would be present for one neuron appearing and another one disappearing, or vice versa, in order to give you the same kind of data. It would be very, very hard to do that, and we also don't see that in sort of other circumstances.
Okay, thank you. Let's move on.